Hello everyone, this is here Yashi, an MBBS student. Here I am covering simplifying the cervical carcinoma. So first we will study the cervix histology. We will all cover the his Robbins histology images. So first cervix, ectocervix and endocervix. Ectocervix comprises of the mature squamous cells. Endocervix comprises the columnar cells. There's a transformation zone which is called as the squamocolumnar junction. So by the image, this is the squamous cells. As you can see, this is the mature squamous cells, ectocervix. They are not susceptible to HPV infection. Immature squamous cells which are susceptible to HPV infection. And these are columnar cells, means endocervix is this. So in between them, there is some squamocolumnar junction which is called as the transformation zone. Here, the immature squamous cells would be susceptible to HPV. So, from this, we get to know the HPV infection attacks the immature squamous cells. So, now we will now start the cervical carcinoma, which is the fourth most common cancer in the woman. Nowadays, the death rate has been declined due to effectiveness of the PAP test. So now we will study the risk factors including in it the HPV infection. HPV infection we will study in detail how it causes the cervical carcinoma, immunodeficiency, as person would be immunodeficient, so this would increase the duration of the HPV infection. There would be persistent HPV infection. Smoking would delay the curing treatment rate. Now the HPV infection. HPV is a DNA virus, so it is having the strains that would include high oncogenic risk and the low oncogenic risk. High oncogenic risk includes the strains that would be HPV 16 and 18, and low oncogenic risk include HPV 6 and 11. So low oncogenic, so it would be benign condition. It would be benign condition, so it would call benign warts. Warts where it could be vulvar, perineal, and vagina. That could called as condyloma acuminatum, which is important as MCQ part, condyloma acuminatum. So now high oncogenic risk 16 and 18, most of the time the more common is the HPV 16 strain for the cervical carcinoma. It increases the risk. Nowadays, I would like to share the prevention of the cervical carcinoma. These are vaccines, Gardasil and Cervarix. Now, this HPV strain get integrated into the host DNA, and this lead to malignant transformation. We will study the pathogenesis, how it do. So first pathogenesis, this viral DNA of HPV get integrated into the host genome. Then they increases the expression of the oncoprotein E6 and E7. E6 and E7 expression increases. E6 would lead to the inhibition of the P53. And P53 is a tumor suppressor gene. So now there would be inhibition of the apoptosis. No cell death would be there. There would be immense cell proliferation. It regulates the expression of the telomerase, which could lead to the cell immortality. E7 expression increases. This inhibits the retinoblastoma gene, and this is a governor. Inhibit the P21 and P27. Again, HPV infection infect the immature squamous cell and replicate in mature squamous cell. So now squamous cell tumors, squamous intraepithelial lesion, which is SIL nowadays, and the squamous cell carcinoma keratinizing and non-keratinizing. Cervical intraepithelial neoplasia, that would be classification in Robbins according to Bethesda system, that is CIN1, CIN2, CIN3. CIN1 is considered to be low grade, CIN2 and 3 are high grade. They are according to dysplasia feature. Dysplasia is a benign feature, not a malignant feature. Anaplasia is a malignant feature as it invades the basement membrane, and in dysplasia there is no invasion of the basement membrane. So LCIL means low grade squamous intraepithelial lesion. It is a cervical intraepithelial lesion 1, mild dysplasia. It is involving the lower one third of the uterus, cervix, sorry. HCIL, it is CIN2 and 3. It is high grade involving the two-third epithelium and third, that is full thickness dysplasia. Carcinoma in situ, it has not invaded the basement membrane. So the Robbins image is here, that is normal, and this is the cervical intraepithelial one. It involved the lower one third. In the two, it is involving the lower two third, and in the third one, it is involving entire thickness but not invading the basement membrane. So this is also a photo in which we are seeing the L cell. Here the coilocytic perinuclear halo. Perinuclear halo, this is a cell. Here this is nucleus and this is a cell. So in between this space is called as perinuclear halo. Now, this is here the HPV DNA infection is there by immunohistochemistry. We have seen it. This is Ki67 positive, which is a highly proliferation marker for HPV. So, this is the PI16 inhibitor. We have seen that it is upregulation of the cyclin dependent kinase inhibitor P16 characterizes the high risk HPV infection. Morphology of the squamous intraepithelial lesion, that L cell involves lower one third and there is mild cellular atypia, but in high grade one, there is lower two-third or entire thickness. Marked cellular atypia, hyperchromaticia would be there. Hallmark of it is coeliocytic atypia would be there. Perinuclear halo, enlarged irregular nucleus. In superficial layer, immunohistochemistry important that it is PI16 positive, PI4, P40 and P63 positive and Ki67 which is a highly proliferation marker. Now, the cervical carcinoma, it involves squamous cell and adeno. Squamous cell is more common, 80% cases, and adenocarcinoma, which is involving the gland forming malignant epithelial, which is 15% in cases. So, now the keratinizing. Keratinizing, always remember when it is keratinizing, then it would be keratin pulse, and the basement membrane invasion would be seen in microscopy as it is carcinoma. So, there would be basement membrane invasion. Non-keratinizing, there would be four dysplasia features and the basement membrane invasion. In the microscopy, as you can see, this is basement membrane and there is invasion. Invasion of the basement membrane, H cell progresses to cervical carcinoma. So in immunohistochemistry, P63 and P40 are positive in H cell squamous cell carcinoma. Clinical features, the female would come to the OPD and she will complain of the post-coital bleeding, post-menopausal spotting. We can suspect of cervical, but for this we would first do the screening for the cervical cancer. That would be pap smear. It includes the two techniques that would be conventional technique and the liquid-based cytology. Molecular method that is being confirmatory, that would be HPV DNA testing. Treatment purpose is surgical removal of the uterus and the radiotherapy. So staging, how we will do staging. So that is called as the FIGO staging. Clinical staging it is. If the stage 1 when confined to cervix, stage 2 when upper vagina is involved, stage 3 when lower vagina and confined to pelvic wall and involves the lymph node, stage 4 when there is metastasis to bladder, rectum or distant spread is there. So nowadays the some prevention technique that is vaccination for both boys and girls by 11 to 12 years of age. There are two vaccines that is Cervarix and Gardasil for HPV strain 16 and 18 and high oncogenic risk, low oncogenic wali 6 and 11 that would cause the condyloma acuminatum, remember it. So here we complete the cervical carcinoma. Please give your feedback in the comment section.